Welcome everybody to the first special speaker series of the Community Liver Alliance. We're really excited to bring you this series this year. It's a new endeavor for the Community Liver Alliance. We're supporting those that we've trained to treat viral hepatitis C and for anybody who is treating patients who have viral hepatitis C. Tonight we have Dr. Divya Venkat. Dr. Venkat works at Allegheny Health Network in the Center for Inclusion Health. Dr. Venkat is also one of our expert trainers for our viral hepatitis C training program. And tonight, Dr. Venkat is going to talk about approach to hepatitis C testing and treatment in people who use drugs. Welcome, Dr. Venkat.
Hi, good evening, everyone. I will be teaching this class, but let me just go through a few things first. So I don't have any disclosures. All of this is based on evidence and my experiences working in this area. I'm just going to give you some background on me and kind of where I'm coming from in my approach to this topic. So I am the co-director of the CIH River Clinic, which is a post-incarceration clinic with the Center for Inclusion Health that's really focused on low barrier and low access care and really increasing healthcare delivery options for those who have been incarcerated. I also help run our Prevention Point Mobile Medical Unit, which is a low barrier buprenorphine access point for patients. And again, really focusing on that harm reduction piece of opioid use disorder. I'm core faculty within our residency program, so I have a lot of experience teaching this topic. I'm board certified in both internal medicine and addiction medicine. And my primary goals as a physician are really to just increase healthcare access from a harm reduction perspective. And when I talk about harm reduction, I really mean meeting people where they are in their use disorder, but also trying to deliver the best care possible. So with that being said, my objectives tonight are, number one, to describe the evidence and the trends of hepatitis C in people who use drugs, to determine the eligibility for hepatitis C treatment and for testing, to discuss strategies for mitigating harms during treatment, and to help you all develop protocols for treating patients successfully for hepatitis C. I'm going to center this whole thing around a patient case. This patient case is loosely based on someone that I've actually seen in clinic multiple times. So just so you know, it's not based totally in fiction. So Casey is a 25-year-old male who presents to your clinic inquiring about viral testing for people who use drugs. After some discussion, Casey endorses intravenous heroin use up to 5 times daily and about 30 bags. He is unsure if he is ready to stop using both intravenous heroin and smoking crack cocaine, but he is interested in being tested for both hepatitis C and HIV. So now it's kind of your job to review the literature about how common is hepatitis C, especially in this population. So just so you know, hepatitis C is really common. And if you're from the Western Pennsylvania region, it is particularly common in our patients. So hepatitis C is actually the most commonly reported bloodborne infection in the United States. It's estimated that about 3.5 million people in the United States are infected actively with hepatitis C. That's about 1.3 acute cases per 100,000. Acute is what we define as less than 6 months. So people are getting infected with this constantly. Right now, the estimate is about 57,500 acute infections in a year. What we have noticed with this data, though, is that hepatitis C cases are actually rising again. It's actually the leading cause of liver transplantation and liver cancer in the United States, and it's associated with significant morbidity and mortality. But the plus side of all of this is it's highly treatable. The only thing we have to combat right now is stigma. I thought this graph was really important to look at. This is actually from the CDC website. And you can take a look at your, whatever state you're from. But if you look at this, you'll see that most of the states around here, so near the Western Pennsylvania region, are above this rate of 1.3 per 100,000 acute infections. And that's a rate. So, and all of these numbers show that there's a higher number in 2019 than in 2018. If you look at Pennsylvania, for example, it says that there was a higher rate in 2018 than 2019. But what we are seeing is that that's actually probably incorrect, and that this data is not exactly up to date right now. You can see in states like Indiana and West Virginia, where there's much more limited access to things like harm reduction supplies, and there's more restrictions around harm reduction and syringe service programs, that this number is actually quite high. I thought this graph, this is another good way of representing the data. So you'll see that, again, so here we are in Pennsylvania. So they're saying that our rate is 0.7 to 1.2. In places like West Virginia, this number is 1.9 to 3. But what's interesting is in places like Pennsylvania, while this is the overall rate of the state, what we actually really need to be focusing on is the metropolitan areas. So places like Pittsburgh and Philadelphia specifically in these cities, but that data right now is not available. So while we look at this kind of data and we're like, hey, things don't look that bad, it's actually a lot different if you look into cities where there might be more, like a much higher rate of infection. So let's look at the available information regarding risk behaviors and exposures, and if these are associated with reported cases of acute hepatitis C as a viral infection. So as you can see, only 15.4% of people, no risk was identified, but in 39.3% risk was identified. The interesting thing though, is that in 45.3% of people, the risk data is missing because we're missing these patients. We're not capturing them. We're not engaging them. We're not having the difficult conversations. So there's this huge piece of the pie that we're not even addressing right now. And that's why I think it's really important to start learning how to engage this population appropriately. Here are the reported risk behaviors. And as you can see, the highest number is with injection drug use. But again, look at this number. The risk identified is 1,302, but the risk data missing is 2,184. That's almost twice as many people that we don't even know if the risk data was present for. So as you can see, between 2004 to 2014, we see that there is a correlation with hepatitis C, acute infections, and opioid injection. And they both significantly increased. So among people aged 18 to 29, hepatitis C increased by 400%, and the admission for opioid injection rose by 622%. So there's a positive correlation with these, right? So more injection drug use, lack of access to care will lead to things like hepatitis C infections. So let's talk a little bit about how does someone who uses intravenous drugs actually get, or inject intravenous drugs or smoking things like crack cocaine, get hepatitis C. As we all know, hepatitis C is a bloodborne infection, and this can be transmitted through needles, syringes, cookers, and tourniquets. So it can occur through a variety of reasons. Sharing needles, but it can also happen by accidental needle sticks if someone is handling a used needle. It can also happen from oral blistering from pipes. So if someone's smoking a crack pipe, which are glass traditionally, and they blister their lips or they have any bleeding that's caused from using that crack pipe, and they share that with someone who does not have hepatitis C, and that person also blisters their lips, they can actually transmit hepatitis C. The other piece of this is also engaging in frequent unprotected sexual contact. So let's go back to the case. You are unsure if Casey should be tested now or when he is no longer using substances. You read the current guidelines and decide to A, test for both hepatitis C and HIV at this time. B, hold off until you can understand Casey's motives, like why is he coming in right now to even get tested. C, explain he cannot be tested until he is no longer using substances. Or D, tell him to seek care elsewhere. What do you guys think?
Okay.
Perfect. Yeah, let's treat him, test them both. The other answers are actually pretty stigmatizing, right? Like, why do we need to understand someone's motives to even test them? It's completely incorrect to say that he cannot be tested until he's no longer using substances. And we should be providing care to everyone. So telling him to seek care elsewhere can actually really demoralize him and make him feel like he shouldn't be participating in healthcare at all. So these are the hepatitis C screening guidelines. This is from the AASLD. And so what they're saying is, as we all know, there's a one-time hepatitis C screening that should be done for anyone at any time. But you also want to be screening people who have a high risk exposure, right? So it's not just a one-time thing. So periodic repeat hepatitis C testing should be offered to all persons with behaviors, exposures, and conditions or circumstances that are associated with an increased risk of hepatitis C exposure. And that this, again, is targeting our patients who use intravenous drugs. So, you're on top of this now. You're like so excited. You're excited to get this guy's labs. So you order both a hepatitis C antibody with a reflex RNA and an HIV P24 antigen. And what you get is a hep C antibody positive, and the RNA is actually 300,000, with an HIV is negative. He returns to your clinic at his appointment time to discuss these results. I put this picture on the bottom because I think it's really important to even think about what our patients are coming into. And it's not just that they want to come in and maybe make our lives difficult. That's not at all what's going on. But as you can imagine, someone's coming in to get these viral test results and they're nervous, right? So we always associate anxiety with things like a temper, like our patient's difficult or a patient has tension or is disorderly or agitated. But anxiety is a real fear, is a real thing here. And so acknowledging that your patient coming in may not be in the best mood, may not want to talk just yet, that's okay. The most important thing is that we're there to support them. Here's another question. How would you proceed with Casey's hepatitis C status? Would you hold off on treatment until he has proven he is abstinent from drugs for 6 months? Unclear if the viral load is acute or chronic infection, and you'd rather retest in 6 months. You inform the patient that he needs to be on medication-assisted treatment, which is a methadone or Suboxone, in order to proceed with treatment, or treat patients regardless of drug use and acute or chronic infection. What would you do?
D.
Perfect, good. So I would treat them regardless of drug use or acute or chronic infection. There's a lot of people who tell you that, oh, they need to be abstinent from drugs, but there's really no evidence to support that. And we'll go through that evidence in one moment. The other thing is when we think about an acute versus chronic infection, our guidelines all tell us we should be treating right away because the medications are so good. So if you look at these AASLD guidelines, again, this is a liver organization. So these people are maybe people who are not focused on harm reduction. They still believe the same thing as us, that antiviral treatment is recommended for all adults with acute or chronic hepatitis C infection. And that's pretty amazing, right? So anyone who has an acute or chronic infection, we should be treating. This is one of my favorite trials of all time because it basically disproves everything that we were taught in med school. So this is the Simplify trial. So basically what they did was they started to treat patients for hepatitis C infection who had either ongoing or recent drug use. And so this is a huge trial for us because before this, everyone was saying, you can't treat someone who's actively using because there's poor adherence, they're going to lose the medication, they're going to reinfect someone. And basically in like the 100 or 200 patients that they had, they only saw one reinfection and one person not complete treatment. And that's amazing, right? For medications that people have to take every day, and it's not easy to take it every day, they actually saw more people completing treatment than not. And it's almost at a 99% completion rate. That's incredible. So if you're ever trying to argue with someone about whether we should be treating these patients, you can always refer to the Simplify trial. So let's jump back to our case. So you decide to initiate treatment. As a part of your screening for social circumstances, you find out the following. Casey is actually intermittently homeless, and he is currently couch surfing. He frequently does not have food and very often skips meals. He's really concerned about carrying around 2 to 3 months of medication at a time. How is he going to keep it safe? Where will he keep it? When I think about this type of screening, I think about the social determinants of health, which is the picture on the bottom. So, we think about this living and working conditions in which a person exists and how this can often lead to difficulties in engaging in treatment. So really quick, what resources do you actually have available in your clinic? How would you kind of tackle this problem?
Social worker.
Awesome. What kind of resources do you think the social worker has? Like, have you ever seen like the social worker deliver something and you're like, oh, that's a really good idea?
I guess I think they follow up with them sometimes on where they stay, or they make sure like every week, I think they have a place to stay in there. Food-wise too, I think they do have some resource. I mean, as far as where I am, at least.
That's awesome. And I think you're absolutely right. You know, when we think about hepatitis C treatment in this population, it is vital to engage a multidisciplinary team. So here are some of the thoughts that I came up with. So number one is utilizing a specialty pharmacy. This is how we're going to improve access to medications for these patients. Number one is a monthly blister pack dosing. I think that's really important because basically you're giving a patient medications in a 1 month supply. And so when you do that, you actually have the patients able to keep track of the medications they're either taking or missing. So you can also be engaged in that. It helps them keep track of the days, and then they're only carrying around 1 month at a time. The nice thing about specialty pharmacies is they have reminders from the pharmacy and they help with drug-drug interactions. We actually get our medications delivered to the clinic, which I think is really, really awesome. The reason we do this is we have a lot of patients who are experiencing homelessness or housing insecurity for some reason. This is safe and secure. You know that the medication is not going to get stolen or misplaced. And it also ensures monthly follow-up with the patients. They have to physically come to clinic to actually pick up their next month of medication. This is what a blister pack looks like. You probably have seen it before. I always think it's a good idea to remember what it looks like and why it's actually helpful for patients. And it's nice because it also defines it by meal. So most people might know what that is. So let's quickly go through the initial labs. I know we talked about this last time, but I'll go through them quickly. What I try to do is when we have a patient who's coming in for Hep C treatment and I'm worried about follow-up, I just get as many labs drawn as possible. If someone tells me like, oh, I'm pretty sure I'm positive for hepatitis C, I just go proceed with the lab work. It's hepatitis C genotype, the FibroSure or the FibroScan, depending what's available to you, HIV testing, a CBC with a differential, a CMP, a PT-INR, a pregnancy test if applicable, hepatitis A antibody, and a hepatitis B surface antigen, surface antibody, and a core antibody. So what are our medication options? Let's just go through those really quick. So I'm just going to review the two pangenomic direct-acting antiretroviral therapies. So one is Mavyret. Mavyret is 8 weeks. It does require food with the medication, and it cannot be taken with an estrogen-containing contraception. Epclusa is 12 weeks. It does not require food with medication, and there's limited use of PPIs and H2 blockers while using this medication. So we're going to go back to our case now. So Casey is really excited. He's like, oh my God, this is so cool. Thank you for really taking the time to work with me and figure out treatment. But he's actually really worried about reinfection and how he might give the virus to others still, especially if he's still using. How are we going to counsel him now? This is where I think we think about how our role on a medical team is really collaborative. While the role of the physician traditionally has been to prescribe medications, I like to think that we've moved past that in medicine in our careers, and we should really be focused on creating a really awesome partnership with our patients to really understand where they're coming from and meet them where they are and whatever they are. So I just want to go over what harm reduction is. So when I think about harm reduction, I think about harm reduction is something that doesn't just apply to drug use. It applies to every part of medicine. It applies to everything that we do. And it's truly meeting patients where they are and figuring out what they need for us in that moment. That doesn't mean that we just do whatever patients want us to do. What it means is that we use our decision-making, our knowledge to figure out a common ground with the patient. because a lot of our patients have actually never had that opportunity. And so these are 4 principles that I've come up with that I think really define what harm reduction is. It's shared decision making. It's not up to the patient, it's not just up to us about what's going to happen. We're going to work on this together like a team. We have to be non-judgmental. It is so important to talk to our patients openly and honestly, and understand that everyone's life circumstances kind of set them up for different parts of their lives. It's patient-driven. The patient kind of decides what the next steps are, and we are there to guide them. We are truly there to guide them along in the process. And it's really important to recognize use while also mitigating the harms. It's okay to be open and honest with our patients. Our patients can tell us what's going on, but we just have to make sure that we also recognize that we're trying to mitigate harms at this point. I'm going to briefly review methods of drug use, because I think this is really important when we start taking social histories in our patients who are currently using drugs. There are multiple different ways that you can use drugs. I'm just going to name a few that are commonly used, or you might hear a bit more often, and then I'll review 2 of the most common ones that really help us, that there's really ways for us to mitigate harms. So you can use them intravenously, intranasally, that's like by snorting, inhalation, which is smoking, skin popping, and muscling, which are both done with needles. So when we talk to our patients, it's really important to ask them where they're getting their supplies from, what kind of supplies they're using, and what their concerns are about their supplies. But you have to actually know how drugs are used. The intravenous drug use supplies are a cooker, a tourniquet, a needle, a syringe, and substrate. Substrate is basically what you cook the drug in. And as you can see, they're laid out on the bottom. So the tourniquet helps you find a vein. The cooker helps you dissolve the drug. The needle is how you pull up the drug, and the syringe is actually where the drug is stored. And the substrate is how you put the drug in the into a liquid form. So a lot of our patients might use crack and methamphetamines. And there's really three major things that we think about. That's the pipe, which is very often a glass pipe, a filter, and that's to make sure that the particles don't get into your lungs, and then the tip. So the tip is probably the most important part of this. A lot of our patients may just put their lips directly on the pipe, and that's where they can get these ulcers and blisters. But you can actually put like a rubber tip on the end of the pipe, and it actually helps you not blister or bruise your lips. What's important though is, it's good to learn how people use drugs, right? It's good to know at least what supplies they're needing. But I think it's also important to know what questions to even be asking. So you want to discuss with your patients how they're using drugs. Are they sharing needles and syringes? Are they personally reusing needles and syringes? Are they sharing pipes? Are they sterilizing the pipe after the use? And how often do they experience blistering after heating their pipe? You want to increase access to harm reduction supplies. This is really difficult in Pennsylvania because this is not like common law. Some states are better than others, but you want to at least direct your patients to the nearest syringe service program where they can get things like new syringes, tourniquets, cookers, the rubber tip for the end of the pipe, and things like Pyrex pipes, which don't actually burn lips. So this is the end of our case and the end of this discussion. So Casey has now completed his hepatitis C treatment with Epclusa, and that's based on your recommendations and you really meeting this patient where he is. His follow-up labs confirm that he has established sustained virologic response, which is so awesome for Casey. And now, because you've built such a good relationship with him, he actually follows you in primary care clinic. So here's some of my takeaway points. Hepatitis C treatment should not be delayed in patients who use drugs, which is something that might be a change in thought, but something that's really, really important. Universal testing is actually evidence-based. There's no reason to delay testing just because someone's using drugs. I think utilizing Hep C treatment to engage patients is really important. I do this all the time. I tell my patients, hey, it doesn't matter if you want to stop using drugs or not, but let me at least treat your hepatitis C. And patients come back, and that opens a whole new channel to discuss with them any other health concerns. If you're still worried about their drug use, be like, hey, you're here for your Hep C treatment, but do you want to talk about that? It really opens the door to establishing a really, really great relationship with people who haven't really been served well by the medical community. It is so important to apply patient-centered care techniques in patients who use drugs. And something to consider is, just like you had recommended, is a multidisciplinary team to improve access for patients. Social workers are awesome. Pharmacists are awesome. Even utilizing your clinic staff, like your nurses and MAs, to really take the patient into your arms and kind of show them that we can care for them is important. These are my references. That's my dog, Nimbu. I thought, you know, everyone this evening might need a little smile on their face. He's my best friend. So this is my email address if anyone has any questions. But are there any questions at this point?
I have a question, actually. I got a patient. He was supposed to start on Meveret, but he was not immune to Hep B. So if they're not immune to Hep A or Hep B, do you delay the treatment, or do you treat them, or how does it go?
So I think the traditional model is you're supposed to immunize someone ahead of time. But the
Right.
problem is, as you know, it takes like 6 months to is it a year, right? To do, it's like 9 months, right? To actually immunize someone against hepatitis B. So we just proceed with the treatment, and then you can immunize later.
Okay.
The only thing you want to be careful of is like if someone has like core antibody positive and it's actually a previous infection. Do you know what I mean?
Yeah. Okay.
I just proceed with treatment though, because honestly, like a lot of times for our patients, that's like our one window of opportunity. Do you know what I mean? Like how often are you going to see a patient for up to a year and then be able to initiate treatment?
Yeah, that's true. Okay. So even if he's taking the treatment, it's okay to share needles with others or anything?
I actually tell them not to. I tell them to, you know, that's what you like, especially during treatment, be like, hey, don't share needles. You know, try to educate them on that kind of stuff. You know what I mean? Like, don't, you know, change your toothbrush. You want to make sure you're not sharing needles. But you want to be able to ask that question, because I think a lot of times people get nervous about like, oh, they use drugs. I can't approach a subject, right? But it's totally okay. And honestly, I think what my patients really appreciate is, even if I don't have that experience, that I'm willing to learn and I'm willing to ask the questions. They're like, oh, it's so crazy that you know about drugs. I'm like, I only know about drugs because I care about you. Do you know what I mean? And I think it builds like a good relationship with your patients. So you don't want them to share needles, but you have to be able to ask the question, are you sharing needles, to even stop the behavior?
Okay. And what do I want to say? I'm sorry, it might sound a very stupid question, but what is skin popping and muslim?
Yeah, so skin, so sometimes when people use intravenous drugs, you can get a lot of scarring, right? So if someone's been using drugs for a long time, or they use methamphetamine, which is like a pretty caustic one, the only way to get the drug in then is to do it subcutaneously, and that's skin popping. So sometimes they'll come in with these wounds on their hands, and that's from skin popping. That actually is like a very, very high infection risk. You can still get Hep C that way as well. Muscling is where people actually put it directly into their muscle, and that can cause a lot of muscular issues as well.
So it's
and get
still like
abscess.
injection, right?
Yep, it's still an injection, but it's not into the vein.
But not in the vein. Okay.
Yep.
Can you comment on the sexual transmission? I'm a little confused here.
Yeah, so usually it's not like the highest sexual transmission rate by any means. Actually, it's more seen in anal receptive sex, just because of the trauma that happens. So you basically have to bleed during intercourse for it to really
in order
happen.
for that to happen.
Do you know what I mean? It's a very, very low chance, but for people who have like frequent unprotected sex and maybe a lot of anal receptive sex, so it might be people who participate in exchange sex or something like that too. You just want to make sure you screen for all of those things as well.
So like a married couple, you're gonna have to screen both of them, I guess, and be treated both of them.
If we need to, yep.
If you have to, okay. So there is still a chance that they can get it.
I mean, exactly. There's a chance. It's a very low chance compared to things like HIV.
Because I remember it was so low from a woman to a male, I guess.
Yes, you're right. It's more common from a male to a female, or a male to a male if there's anal receptive sex.
Okay.
Doesn't matter who it is, but yeah, you know what I mean?
Yeah. Okay. Just to clarify. All right. Yeah.
Okay, those are great questions.
Okay.
It looks like you're the only person here. Is there anything else you have questions on,
That's
or anything
like,
else I can help with? That's my email address. If you ever have any questions, feel free to email
Yeah,
me.
I got it. I got
I'm
it.
pretty responsive.
Oh, thank you. Sure.
All right, awesome.